Hi, good evening, and thank you for joining our educational webinar with Dr. Phoebe Ashley and Dr. Deborah Koehn, who will discuss how VCU Health Pauley Heart Center's Complex Lipid Management Clinic will partner with you to help improve your cholesterol by helping you to establish new lifestyle habits and providing medication to manage complex lipid disorder. I'm Pauline Jankowski, VCU Health Pauley Heart Center Marketing and Communications Manager. Before we begin the presentation, we encourage you to drop any questions you may have in the comment section throughout the event, and we will address them during the Q&A portion. And now, introducing the speakers. Dr. Ashley is a non-invasive cardiologist at VCU Health Pauley Heart Center with a special interest in preventive cardiovascular medicine and women's cardiovascular medicine. Originally from Eureka, California, Dr. Ashley was an assistant professor in the Department of Medicine at the Albuquerque Veterans Administration from 2001 to 2003, and then a non-invasive cardiologist with Oregon Cardiology from 2003 to 2011, working at both the Sacred Heart Medical Center in Eugene, Oregon, and the Mackenzie Williamette Hospital in Springfield. Prior to joining VCU in 2014, she was a non-invasive cardiologist with Providence Cardiology Associates in Olympia, Washington. Dr. Ashley takes a holistic approach to cardiovascular care through the various stages of life for women and men. In collaboration with the American Heart Association, she works in our communities to promote awareness and empower people of all ages regarding their cardiovascular health. And Dr. Deborah Koehn, a primary care physician, has focused her care on high-risk patients with diabetes and cardiovascular disease. In caring for a complex group of patients, she has discovered that traditional medical treatment alone has not proven to completely resolve concerns and improve the quality of life for her patients. She meets her patients at their stage of readiness for change and helps them understand and address some of their challenges they face in changing food behaviors that are detrimental to their health. She has developed a diabetes education class series, a multidisciplinary education program involving culinary medicine, exercise physiology, endocrinology, pharmacology, and nutrition at VCU Health Stony Point's Women's Health Facility, helping to lead VCU Health to be an American Diabetes Association approved educational site since 2016. Thank you, Dr. Ashley, and thank you, Dr. Koehn, for joining us today. I will now turn the show over to you.
Good evening. We're very pleased that all of you could join us this evening, and we'll begin now. If I could have the first slide. We're going to look tonight at what is cardiovascular disease, and we're going to do that through the journey of a patient, Mrs. R. We're going to look at lipid metabolism. We're going to talk about knowing your numbers for each of you, and then a little bit about lifestyle modification as well as medications. Next slide, please. So Ms. R is a 68-year-old woman who has high blood pressure, she has hypothyroidism, and she has high cholesterol. She also has tobacco dependence, and she presents for her initial evaluation of high cholesterol. She says that she's been experiencing some mild shortness of breath with activity. She does walk briskly 5 times a day, and she also has quite a bit of life stress. In addition to her presentation, she has a history of being pregnant 1 time with a cesarean delivery. Now you might ask, well, why does that matter? Well, actually for women, your pregnancy history is very important. Pregnancy is considered a woman's first cardiovascular stress test, and any woman who experiences high blood pressure, high cholesterol, a premature delivery, a small for date baby or a large for date baby has failed their first cardiac stress test and will have earlier heart disease than their peers. So it is an important thing for the women in the audience. This woman also has evidence of left ventricular hypertrophy, which is thickening of the heart muscle and is related to having longstanding high blood pressure in most cases. She also has vitamin D deficiency. Next slide, please. She does take medicine for her thyroid. She takes 3 medicines for her blood pressure and some over-the-counter supplements. She has allergies to almost all the medicines she has tried for her high cholesterol. She has tried several statins, and she has also tried niacin, all of which gave her muscle discomfort. She does have additional risk in that her mother had heart disease. Her mother also had breast cancer. Her father had kidney disease related to high blood pressure and then end-stage renal disease. And her sister has diabetes. She is retired, but she remains an active smoker. She began smoking at the age of 17 and has been smoking a pack of cigarettes a day for over 50 years. She does not drink alcohol or use any drugs. Next slide, please. On her examination, it's notable for her heart rate being a little bit high for a lady who walks briskly 5 times a day, or 5 times a week. I would expect her heart rate to be a little bit better controlled. Her blood pressure is elevated. Her weight is a little bit high. Her BMI is 28.28. We'd like to see it under 25. The remainder of her exam is fairly unremarkable, save for her cardiac exam, which has a unique finding, which we'll see is related to her EKG, and she does have a low cardiac murmur. On her EKG, she has a normal rhythm, but she does have a new right bundle branch block. Those can be related to conduction disease, they can be related to coronary artery disease, and to a couple of other findings. So that's something that we have to pay attention to as well. Next slide, please. So what is cardiovascular disease? Well, it's a large umbrella of diseases. We take care of coronary artery disease, which is what we'll be focusing on this evening, but we also take care of high blood pressure, valvular heart disease, arrhythmias, things that people are born with, what's called congenital heart disease. We take care of vascular disease in the cerebral vascular system and the peripheral vascular system. When we talk about coronary artery disease, you can see in our pictures that we'd like to have the artery nice and open, but over time, plaque can develop. And when patients present with chest discomfort, it's usually because there has been some limitation to that little tube where the blood flows. So it can be that plaque has built up and closed off part of the tube. It can be that the tube spasms down on itself. Those things that limit blood flow are what we call angina. The patient presents with chest pain, and that chest pain is called angina. When that artery is completely blocked, closed down completely, either from spasm or from a plaque or from a clot, then that's called a heart attack. That's when the artery's closed and the rest of the blood vessel is not getting any blood flow. Consequently, the muscle's not getting blood flow and the muscle will die unless the blood flow is reestablished. Next slide. So let's take a look at Mrs. R's lipids. We have a spectrum for her from 2013 to 2018. And things that stand out are that her total cholesterol tends to be quite high, well above 200. Her HDL actually is low. HDL for a woman, we like to see at 50. Hers is down in the 40s. Her LDL is also elevated. And she was, you can see at the bottom of the chart, when she was taking some medicines, the LDL would be a little bit different. When she was not on anything to control her cholesterol, her LDL was 250, which is exceedingly high. Our goal for LDL is less than 100 in the average individual and less than 70 in a person who has known vascular disease or diabetes with an additional risk factor. She also has variability of her triglycerides. Next slide, please. When we look at our cumulative risk based on our lipid profile, we would like to be in the bottom row of the chart above. So if you can see that the LDL at 80 over the course of your lifetime, by the time you're 60, you have a 1% chance of having a heart attack. But if you have an LDL that's over 200, your chances are well above 16% because we are off the chart now. So an individual who has a cholesterol of 125, we already know that their risk as they age, at age 60, they're going to have at least a 4% risk, and the longer they live, their risk will steadily increase. That's why we like to see improvement of cholesterol earlier in life as opposed to just taking care of it at the time of a heart attack. Next slide, please.
Okay, so I'm going to take a minute here and I'm going to go over some of the normal lipid metabolism. And it's important to understand this so that when we talk about our numbers later on as to what you get on your lipid profile, you can understand where those numbers come from. So typically, when we ingest a meal, that fat in that meal gets broken down within your GI tract. And those fats are too big to be absorbed. So they're broken down, absorbed through the gut wall, kind of repackaged, and then shuttled to the liver through what we call the portal vein. So they don't see the general circulation. They're taken right from the gut and brought to the liver. And during that packaging, they're packaged up into these triglycerides. Next animation. So the triglycerides are delivered to the liver. The second part on the next slide is the liver is responsible for producing the molecule of cholesterol. And you can see that there is a metabolic pathway that occurs here for producing that, hormone, and so, or that protein. So you can see that this pathway is regulated by that HMG-CoA reductase, and actually that's where our statins act, and we'll come back to that. So moving to the next slide, you can see that now we have had our triglycerides delivered from the gut. The liver has synthesized that cholesterol. Now those are fats. So how are we going to deliver that energy to the periphery? Well, the blood is like water, and we know that oil and water don't mix. So we have to find a safe way to deliver those fats to the periphery. So we're going to package those up, those triglycerides and that cholesterol into a package, and that's called a lipoprotein. And that lipoprotein on the outside can interact with our bloodstream, what we would consider like the water, and then inside is where all the fats are kept, nice and tight, okay? So when that particle leaves the liver, the next slide, you are going to package that into a particle called Vldl, and it gets marked with an ApoB protein. So every single molecule that is atherogenic or can cause disease, when it leaves that liver, is going to be marked with one ApoB protein, okay? That's going to be important later when we look at some of our numbers. Okay, next slide. So now we have this VLDL particle, and you can see that the yellow parts, the little yellows on the inside of the triglycerides, the blue are our cholesterol. And so its job is to travel through the body and to deliver that energy source, the triglycerides, to our muscles, which need it for an energy source. All the extras kind of get sent to our fat tissue and stored. And as that VLDL gets smaller and smaller and smaller, you can see that that VLDL has been transformed into something that we call LDL, okay, or low density lipoprotein. It means that it's now stuffed with lots of cholesterol and not so much triglyceride, okay? It still has that one apolipoprotein B particle. Next animation. So now you have this very, very small LDL particle, and it can just diffuse right into your vessel walls and start to cause disease. Next animation. So when it gets into that vessel wall, it's not supposed to be in your vessel wall, okay? And it starts to develop that plaque. That LDL within the vessel wall is a foreigner, and your whole body, it sets up an entire inflammatory process to deal with this foreign product that's in the vessel wall. That vessel wall should be nice and smooth, and now it's got this LDL in there, and it's not supposed to be there. And so you have that inflammatory reaction, that plaque forming, with the risk of it rupturing and causing that heart attack or stroke, like Dr. Ashley was talking about earlier. Next slide. So that's why, you know, Dr. Ashley and I were both talking about that we want to have that LDL as low as we potentially can get that, as early as we can get that. Because if we start with an LDL of 80 when we're young, that risk as we age, that's the bottom line, of potentially having an event remains rather low, okay? An LDL of 125, you know, our risk goes up as we age. But let's say at age 50 here on our chart, you can see that there's a little bit of a branch on our graph. If we decide at that point to start therapy and lower that LDL level to an 80, which if I had a lifetime level of 80, my risk remains low. But if I push it down at a later date, I may get to an 80, but my risk is not as low as having a lifetime low level of that 80. I hope that makes sense. Okay, next slide. All right, so what can we do? So we want to start early and we want to work with prevention. And so prevention first begins with how we eat. It is the foundation of caring for our heart, our brain, for managing our blood pressure, our cholesterol. It is the bottom of every pyramid, food pyramid that is out there. Next slide. And so what we're going to talk about before I jump into the Mediterranean diet is I'm going to first go over what those numbers are. So we just talked about normal lipid metabolism, okay? So cholesterol, as I said, is a fat. It's this waxy fat-like substance. It was produced by the liver, and we can also find it in dietary sources, but it's not as important. And we carried it through the body in those lipoproteins. So as I said, that LDL, or otherwise known as our lousy cholesterol, can get deposited into the walls. That high-density lipoprotein, or that HDL, is responsible for removing cholesterol from your vessel walls and taking it back to the liver to be remetabolized. So when we look down here at the bottom, this is to know your numbers. For somebody who does not have coronary artery disease, who's working on primary prevention for not having a stroke or a heart attack, their total cholesterol we'd like to see less than 200, and LDL less than 100, and that HDL over 40 for men and over 50 for women. Now, if we have known coronary heart disease or cerebrovascular disease, which is the blood vessels to the brain, that LDL needs to go even lower. That has to be less than 70, okay? Next slide. So our triglycerides that we've talked about before, now these are very important lipids. They're transported in our bloodstream with that cholesterol. They provide energy sources. But as we know, that the higher those triglycerides go, the lower our HDL is, okay? They're in a reciprocal relationship with each other, all right? And as we start to see that change where we have high triglycerides and low HDL, that is a sign for an increased heart attack or stroke risk, especially when it's paired with an elevated LDL. Now here we're going to talk about that apolipoprotein B. Remember, every atherogenic particle, any particle that causes disease is going to have one apolipoprotein B. So when we check our blood work, we get an LDL-C, right? But that's only one of those particles. Remember, we had that VLDL, it had an ApoB attached to it. When it's kind of intermediate, it has an attached B to it. And then when it's at the LDL, it has a B attached to it. So when I measure an apolipoprotein B, I'm getting a measurement of all of those particles that potentially can cause disease, okay? And in primary prevention, we want that to be less than 90. And in individuals that have heart disease, we want that to be less than 80. We also have this other particle out there. It's called lipoprotein little a. And it is attached to our LDL. And when that particle is measured and it's higher than 30, that really increases our risk for early cardiovascular disease. And you can think about LP little a as like this very mischievous little key. If it's hanging on to the LDL, and LDL normally, diffuses into that vessel wall, this is the one that, opens the door faster and allows the LDL to get into that vessel wall more quickly and accelerates that disease. So we want to make sure that LP little a is low. Right now, we don't necessarily have treatments to target this particle, but it does alert us to an increased risk for early cardiovascular disease. So I try to check that on every single one of my patients that come to my clinic once, so I know where they stand. And this is kind of genetically inherited. Okay, next slide. All right, so the last know your number is, we talked about how when that LDL particle moves into the vessel wall, that it's foreign. It's not supposed to be there, and our body will react to it, send in all this white blood cells and all this thing, and it's causing lots of inflammation in that plaque, okay? We can measure that through looking at a high sensitivity CRP. And what we found in our studies is that we really want that high sensitivity CRP to be less than 2. Regardless of where our LDL is, we need to also have that inflammatory factor low, less than 2. If it's higher than that, then we want to be looking at things either through our diet or through our medications to help lower that inflammation. Okay, next slide.
So we look at our risks as a cumulative thing. So it's not just high cholesterol that leads to heart disease. So we do have risk calculators that help us assess what your 10-year risk might be. And there are numerous calculators for that. Most of them will assess what your age is. Some will ask about gender, race. They will all ask a component of the cholesterol profile. Usually they want to know what the LDL and the HDL are. They will ask about your blood pressure, which is usually they're asking for the top number of your blood pressure, the systolic blood pressure. They want to know whether or not you have diabetes and whether or not you're a smoker. So when we look at our lady, she is 68, so she's over 50, and as for a woman, anyone over 65 is already at increased risk. She, as a woman, well, we know that men tend to have heart disease a little earlier than women do. Now that can be a little bit misleading, because by the time we are all 40, we have an equal amount of cardiovascular risk. So for the ladies in the audience, don't sit back and think you don't have to act earlier, like Dr. Koehn was describing. You need to get that LDL down earlier in your life and not wait until you're postmenopausal. Our lady, though, also has an elevated high cholesterol. She has a relatively low HDL for a woman, and she is still actively smoking. Now, smoking causes inflammation in the blood vessels, and we already know that that's a problem. When those vessels are inflamed, they're at greater risk for some of that plaque developing. That LDL can't get out. It's caught up in that inflammation sometimes, so that can be a problem. Next slide, please. When we talk about the risk calculators, there are newer risk calculators that are actually incorporating what your coronary artery calcium score is. Now that's a simple CT scan that's done. It's a one-time image. It's not a physiologic test. It's just a one-time image where they take a picture and they look at how much calcium you have in your arteries, and they tally up a number. They will look at all of the coronary arteries. So we have a main artery that comes out. It then splits into 2 arteries on the left side, and then we have one on the right side. So they look at all of those arteries and will tally a score for you. And the higher the score, the greater your cardiovascular risk. Next slide, please. So when we look at the picture on the left, you can see the arrow is pointing to very, very bright changes in the heart. That's actually calcium in the coronary arteries. Those arteries should look nice and dark, as you can see sort of on the right side. I don't have an arrow to show you, but on the other side, you don't see much calcium in where that other blood vessel is. But in that main artery that's coming down, there's a tremendous amount of coronary calcification in that artery. So when we look at calcium scores, if you have a score of 0, we are thrilled. That's a wonderful thing. Once you have 1 to, up to 11, you are starting to have at least mild coronary artery disease, but probably don't have significant narrowing of your vessels at that point. Once you're over 100, we're starting to see that you're going to be having some degree of narrowing. For someone to have angina, that part where we have the chest discomfort because of limited blood flow, the artery has to be 70 to 75% narrowed before you will even experience any angina. But a person who has a calcium score over 400 is very, very likely to have significant narrowing of their coronary arteries, and they're more likely to be the ones that are having angina when they are doing activities. I will just say one caveat about angina. Many people have typical angina, which is chest heaviness, pressure, tightness, and over the breastbone. It can radiate to the neck or jaw or down into the arms or into the back. But many people also have what's called an anginal equivalent. They don't get that chest heaviness or pressure, but they're short of breath when they walk, like Mrs. R, or they get very tired when they walk. They might get nauseated with the different activities. There are other things to consider that could still tell us that there's a limitation of blood flow to the heart. Next slide, please. Just a caveat about coronary calcium scoring. You can see on our little diagram that a type 2 lesion is really where we do not have any plaque yet. We just have some foam cells in the outer aspect of the blood vessel. So that would be a calcium score of 0. We then develop what are called soft plaques. Now the problem is that soft plaques are not identified on a coronary artery calcium score. So you could already have some degree of plaquing, but if it hasn't been calcified yet, it will not show up on that CT scan. Women are at greater risk of having soft plaques. So again, a calcium score of 0 is great, but if we're missing a soft plaque, that could still be an issue. So really working on risk factors through your lifetime is very important. As we move along the spectrum of our plaque development, we can still have a plaque that's very, that really is starting to be building up inside the vessel. That's usually when the calcium score has moved into about 100. And then as it gets greater than 100, we have true plaque that is taking up space in the lumen of our blood vessel. Next slide, please. So this is Mrs. R's coronary calcium score. And I would guess that many of you would say that she has a lot of calcium, and she does. Her calcium score comes out as 485, which is very high, placing her at a very high risk for heart attack in the near future. With regard to the calcium score, I didn't mention in the beginning, calcium scores are not always paid for by insurance. The cost of the calcium score is about $99. It is a very helpful test to help us determine your overall risk when we're looking at coronary artery disease. And as I mentioned, many of the newer risk calculators are incorporating your coronary calcium score into the risk profile. Next slide.
All right, so for Mrs. R, she's had a lot of difficulties with her medicines, and we are going to need to find something for her. But before we even begin down the journey of looking at the different medications, we have to come back and deal with that foundation. And that foundation is, what are we eating and how are we living? So let's talk a little bit about the Mediterranean diet. Next slide. The Mediterranean diet is probably the only eating pattern that has shown cardiovascular benefit, okay? It is also the most well-studied eating pattern that we have looked at. So there's over 40,000 studies looking at the Mediterranean eating pattern, from cardiovascular disease, for weight management, for memory issues, for cancer, diabetes, fatty liver disease. You can pretty much name any disease state. And this eating pattern has been studied in that setting and has had very good outcomes because it's palatable, it's affordable, and it's sustainable. So those are all very important things. So it's not a diet, but it's an eating pattern, okay? It's a way of life. So next slide. So when we look at the structure of the Mediterranean diet, you know, the bottom is our nice olive oils. And then the next part above that is our fruits, our vegetables, our nuts, our seeds. And all those plants are kind of the foundation of that eating pattern. And then above that, you might have some fish, maybe some poultry. And then on the very, very top, you're going to have very, very little of the red meat or sweets. So those will be less frequently, maybe once or twice per month. But that everyday eating is going to be mostly those plants. So it's learning how to cook differently, change our recipes up a little differently to incorporate more of that foundation base, okay? So next slide. So let's break it down. There's several components to the Mediterranean diet. And as I said, the first one is our vegetables, our non-starchy vegetables. And what we have found is that each additional serving of our vegetables can reduce our risk of cardiovascular disease by about 4%. So a serving is about a cup of raw or a half cup of cooked vegetables. So think about that. When you eat a salad, do you eat just 1 cup of greens? Probably not. You know, a salad is usually 2 to 3 cups of vegetables. Well, great. You have 2 to 3 servings of your vegetables for that day. And every time you make a recipe, you want to ask, can this recipe handle another vegetable? Where can it be added? Can I hide it in a sauce or in, you know, within a dish that I'm making? Okay. Next one, please. Second one is legumes, and these are very important because they're a beautiful protein to have in our diet. They offer us protein, carbohydrate, fiber, and lots of micronutrients. So when we pull our protein from animal sources, it's very high in saturated fat, but plants don't have saturated fat. So that naturally is going to lower your overall bad cholesterol, okay? So eating your legumes, your beans and your lentils by about 4 times per week reduces your heart disease by about 22%, okay? A serving of that is about a half cup of cooked beans or lentils or 2 tablespoons of peanut butter. Remember, peanuts is a legume and not really a nut. All right, next slide. Fruits and nuts, they get lumped together in the Mediterranean diet. And we look at that as a serving about 1 ounce of nuts, a small piece of fruit, a cup of berries, half a banana, a cup of melon. And so we want to add, you know, nuts to our oatmeal and our salads. If we're somebody who likes a salty chip, substitute that out with a nut. And you've added 1 more ingredient of that Mediterranean diet to your daily routine. If you have a sweet tooth, do a piece of fruit instead. Next slide. Next slide, please. Great. So cereals and whole grains, this is really important. We want a diet that's high in fiber. So fiber is going to come from those non-starchy vegetables, nuts, seeds, cereals, and whole grains. We live in an environment now where people are, you know, low carb, no carb, but honestly, these whole grains are really high in fiber. They trap in the bad cholesterol and it's excreted through our stool on a daily basis. We do not want to exclude our whole grains. And we notice that when we look at many different cultures throughout the world, the ones that have the lowest heart disease are the ones that eat the highest amount of whole grains. So whole grains can be a whole slice of whole grain bread, half cup of oatmeal or quinoa, half cup of whole wheat pasta or brown rice, or a half cup of that starchy vegetable like a corn, a pea, or a sweet potato. So when you're looking at your labels, the labels on the front of something you're purchasing, if they say, you know, oh, it has whole grains, don't read the labels. Flip it over and look at the ingredients. If the ingredient reads enriched, then you have kind of a white flour or a white bread. You want to read on the ingredients whole grain or whole wheat, and then you know you have the type of food that you're looking for. And remember that popcorn is considered a whole grain. It's a 1 ingredient food. 3 cups is a serving of popcorn. Also a great way to swap out for a healthy, salty snack in the day. Next slide, please. Fish. This is a really integral part of the Mediterranean diet, and we typically ask about twice per week to have fish. So this is great. Substitute fish in for a typical red meat meal that you might have. It's quick and easy to make. You can poach it, bake it. Some patients really like a deep fried fish, so I'll compromise and we can do a pan fry. That's much better than a deep fry. But think about, you know, salmon patties or using tuna fish. Those are all count towards your servings of 2 per week. Next slide, please. fats and oils. Mediterranean diet really was based on extra virgin olive oil, because not only is it a plant-based oil, but it's very high in phytonutrients, which provide a lot of antioxidants for our diet. But if you don't like olive oil, any plant-based oil, liquid at room temperature, is healthy. We do not want solid fats or oils. We don't want butter, and we don't want coconut oil. We don't want Crisco. Those are going to be saturated fats, and those will raise our bad cholesterol. Next slide, please. Dairy. When we think about the Mediterranean diet, they didn't sit down and drink cups of milk. Their dairy was small portions of like a feta or a Parmesan that would add a richness and a flavor to their foods. Or it would be a non-fat plain Greek yogurt, which was high in protein also. And remember that yogurt is actually sour. But the United States, we make everything sweet and have this added sugar. And it's actually a sour food. So it's okay to start with that non-fat plain Greek yogurt and add your berries and nuts to it. Those are all whole foods and end up being a very healthy dish. If you are going to do some traditional cow's milk, we ask that you do non-fat milk, not 1% or 2% or whole milk, really non-fat. Next slide, please. Meats, we want lean meats. And so we do ask that you omit any of the processed meats, which can be very hard in the American diet. But we ask, no pork or turkey bacon, no pork or turkey sausage, deli meats, bologna, ham. Those are all very processed meats. And they're going to be high in sodium, high in nitrates, and high in saturated fat. So we really want those removed out of the diet. If you are going to do a red meat or a pork, really look to lean. Look for that tenderloin. And remember, it's only 3 ounces. 3 ounces is about the palm of my hand or a deck of cards. And remember, a deck of cards is not that thick. So if we are going to have meat, it's going to be a side dish and never our main dish. It will be a flavoring to what you are making. Next slide, please. Alcohol is a part of the Mediterranean diet. Our scientific advisory that helps to produce our dietary guidelines actually recommends no more than 1 drink for both men and women or none. Even though our dietary guidelines still support 1 for women and 2 for men, the actual scientific guidelines say 1 to none. So if you don't drink alcohol, we recommend that you don't start. But if you are drinking alcohol, we really want you to know your portion sizes. So that's a 12 ounce of a beer, 5 ounces of a wine, or 1.5 ounces of liquor. And if you have such disease stages like heart failure, liver disease, any history of addiction, breast cancer in particular, we really ask that you refrain from drinking. Next slide, please. So one of the important things is that our eating pattern does not have to be perfect. If we're going for perfect, we might as well just quit because it's not going to happen, okay? But we can do better. And so what's important when we're looking at the Mediterranean diet, we're like, well, I could do nuts. I could do whole grain bread rather than white bread. Phenomenal. You've just made 2 important changes in your diet, moving your way up that Mediterranean scale, and you've decreased your total mortality by 25%. Now, I can give you a statin and treat you for 5 years, and that reduction is 21%. So why not do that diet and create that as your foundation for treating our high cholesterol and preventing heart disease and stroke? All right, next slide. So in addition to our diet, we're now going to talk about medications.
And one comment that I'll make that I share with my patients is that life is really a measure of moderation. You have to be moderate in the things that you do, particularly when it comes to your diet. So really be conscientious about your portion sizes and the choices that you make for the foods that you place on your plate. In looking at the medications, we can work as hard as possible on our diet, but in most cases, we improve our cholesterol by at most 20% to 25% reduction in mortality, but 25% of improvement in the cholesterol itself. So we often need to add medication to try to help get us to that goal level. particularly for someone like Mrs. R, who's bad cholesterol. That LDL is in the 200s on no therapy at all. Even with her best diet efforts, she would not get herself down to that less than 100 level. And now we need her less than 70 because we know she has coronary disease based on her calcium score. So when we talk about the medications for cholesterol, statins are well known by most people. And I feel that really one of the greatest benefits of the statin is its reduction in inflammation, even more than its ability to lower your bad cholesterol. But the statins do work, as Dr. Koehn mentioned earlier when she was talking about lipid metabolism. They work early in that HMG-CoA's reductase enzyme. So they block that, and that helps lower our cholesterol. They help to clear it away. Next slide, please. When we look at the dosing of statins, high dose statins are more effective than the lower dose statins. We consider atorvastatin and rosuvastatin at 40 and 20 milligrams to be high intensity statins. And many times we have to place our patients on 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin. Moderate intensity is going to lower our LDL anywhere from 30 to 49%, whereas our high intensity is going to lower that LDL by greater than 50%. When we use low intensity medications for some people who are not able to tolerate the statins as well, like Mrs. R, then we're only going to really make a dent of 30% in our LDL. So the diet in her case is very important to help improve her cholesterol performance. When we talk about side effects with the statins, one that is most common is muscle discomfort. I often have people take coenzyme Q10 when they take a statin. There is one trial that suggests that if you take the coenzyme Q10, there's less of a chance of getting the muscle aches, but some patients do develop muscle aches, so that can be one issue. A small percentage of people might have a little elevation in their liver enzymes. That's why your doctor will order your lipids and sometimes check your liver function as well. And then in some people, it goes up a little bit and we are fine with that. It's when the liver enzymes go very high that we have to think about changing the dosing or stopping the medication. Actual liver disease is extremely rare to develop from statin therapy. Next slide, please. We also have an agent called Benpedoic Acid, which also helps us to lower our LDL. It works in a different spot in the cascade of the lipid metabolism. As you can see at the bottom of this slide, it's going to work at the ATP enzyme. You don't need to know that. You just need to know that it can be an adjunct to what we're doing with the statins if we still need to improve our LDL. Next slide, please. Then some of you may be familiar with the medication called ezetimibe or Zetia. This actually reduces absorption of cholesterol in the intestine. The most common side effects with this medication could be a little bit of GI upset. So some people will have some bloating or some indigestion, sometimes some abdominal pain from the Zetia. Many of my patients seem to tolerate it just fine. It's a one dosage. It's only 10 milligrams, and it's added to the LDL or the Benpedoic acid to try to help get us to our goal for the LDL. Next slide, please.
Okay, Pheno Fibrate is one of our older medications, so it's not a first-line medication anymore. But we can often use this in combination with the medications you've already heard about. And so it can help us to lower our triglycerides, decrease our high-sensitivity CRP, that inflammatory marker, as well as our LDL-C. We do have to watch for increased muscle aches by itself, as well as when it's in combination with these other medications. But I will often pair this with Zetia in individuals who have a lot of statin intolerance and who are only aiming for like primary prevention and don't have to get as low as they need to go. It's not a very potent drug, but we can still use it and it still does a good job. Next slide, please. So our omega-3 fatty acids, or our fish oils, we have two medications on the market. Lovesa is an EPA DHA, and Vascepa is a straight EPA. And what we've seen is that it helps to lower triglyceride synthesis and production and packaging. And so this can be used for people who have very high triglycerides, over 500. And it's now been FDA approved for using for individuals that have triglycerides between 250 to 499 that have that kind of intermediate risk. It also helps with decreasing cardiovascular events after somebody has already had an MI. So there's lots of different places where we can use this medicine. Next slide, please. Our Pcsk9 inhibitors are our newest friends on the block. We originally found out about this medication by studying other populations who had really early heart disease in their family, and also studying populations that had no heart disease in their family. And what they found is that individuals that had a lot of Pcsk9 hanging around, they had very early heart disease, because what would happen is that particle would bind to that LDL receptor. And when that LDL receptor got taken in with that LDL bound to it, to the liver would see that signal and destroy the receptor, break down the LDL, and break down that Pcsk9. And then that receptor didn't go back up to the cell surface or up to the top of the liver to pull in more of that bad cholesterol. So those people had really high cholesterols and very early heart disease. We found another population of individuals that had a mutation where they had 0 to none or very low levels of that Pcsk9. So that receptor would get that LDL, bring it into the liver would process the LDL, and then that receptor would say, oh, I get to do that again. And it would go back up to the surface of the liver to pull down another bad LDL. And so they had very, very low levels. Now we have medications that interfere with that particle so that we can have continual cycling of that LDL receptor. And we get really nice low LDL levels. And so we are using this a lot in patients who are statin intolerant or who need to have very low levels of their LDL or have had multiple events. And this does an excellent job, and we don't have those muscle side effects, and we have very minimal side effects. Sometimes some injection sites, because it is an injectable medication, either once every 2 weeks or once per month, but really very minimal side effects with it. Next slide.
So we've talked a little bit about diet, we've talked a little bit about medication, but let's speak a moment about what else we need to think about. When we talk about cardiovascular risk factors, first and foremost, your greatest risk factor is actually your family history. So learning and understanding about your family and who may or may not have had heart disease is very important. Mrs. R's mother had heart disease, so that was an important risk factor for her. We know that diabetes is an independent risk factor for heart disease, smoking, high blood pressure, of course, high cholesterol. But we also know that inactivity, sleep apnea, significant stress can also be important risk factors for people. Next slide, please. We'll just talk about a couple of those. One is the activity aspect of things. Dr. Stephen Blair showed us years ago, that modest exercise decreased our heart disease deaths by 50% in both men and women. Dr. Koehn and I do not have a single medication that we could offer you to give you that good of a reduction in your death rate from cardiovascular disease. Next animation. The problem is exercise requires a little bit of motivation. So if you are one of those people that has a hard time putting your foot out the door to take that walk, find a friend. Find some other activity that you like. Perhaps you don't like walking, or you don't like swimming or jogging, but you love dancing. That is a great form of physical activity for you. But it's always easier to do it with a friend because it makes it more fun and you have a little accountability. Next slide, please. When we talk about exercise, I'd like to see people exercising at least 40 minutes to an hour of aerobic exercise daily. For those individuals that are trying to lose weight, the recommendation is at least an hour every day of aerobic activity. And then that needs to be paired with strength training. So that should be done at least 3 times a week. And that doesn't mean you have to go to the gym and pump iron. For some people, it could just be taking those cans of beans out of your cupboard and using them while you're watching TV, doing some little exercises to build that muscular strength. Next slide, please. Another thing that's very important is stress. Stress causes more inflammation within the body itself. So we do need to figure out how to manage stress. And really there are two components to that. One is to change the environment that is causing this significant stress for you. And the second is to change the way you respond to that environment. And that can be with mindfulness. It can be with different classes where they talk about different techniques. I talk a lot with my patients about breathing techniques and how to improve their stress level. Sometimes medications are needed if you have extreme anxiety related to the stress, because that is impacting your cardiovascular system all the time you're experiencing that. Next slide, please.
All right, so Miss R. So the one thing that she did, and she did really well, is she actually stopped smoking. And yeah, and she started when she was 17 and she stopped in her 60s. So really phenomenal job. She also worked on her diet. She omitted some processed meats, eating baked goods rather than fried, decreased her sodas, increased her water intake, as well as started to look at her basic recipes that she was doing every day and figured out how to add her fruits and vegetables. Now for her meds, she wasn't able to tolerate the statins and she wasn't able to tolerate Zetia. So we went on ahead and started her on Repatha, and she's successfully been on this for 2 years now with no difficulties. And her LDL is now down at 45. Her ApoB is 54, and her high sensitivity is 104. So I would consider Mrs. R a great success. Thank you. Questions?
Wonderful. I'm taking so many notes and I'm like, oh gosh, I'm eating all the wrong things. This is terrific. Thank you so much for presenting and sharing with us what we should do and what we should not do, and we should not be perfect, which is great to hear, but we can make improvements. And seeing that statistic, I don't know why I'm struggling with that word, but with the statins, using that for 5 years versus doing the Mediterranean diet, what a difference that makes. And you're probably a little bit happier as well along the way. So so we have some questions that came in. Let me see right here. So, I'm sorry if you addressed this, but, are there actually, like, when we're going through our days, and will I have a symptom or some kind of sign that my cholesterol is high?
So there are no real symptoms of cholesterol being high. That's one of the challenges of it. The symptoms develop after the plaque has developed in the coronary arteries and you begin to develop angina. But there are some signs that you can find when you look at a person who has very, very high cholesterol. We can see what are called xanthems, and there on your eyes, you see this sort of yellow, like patches around the eyes. Mm-hmm. You can see some early arcus senilis, which is when you get a white rim around the cornea of your eye. Now we see that with aging itself, but it can be associated with people that have very high cholesterol earlier. We can see xanthomas where you actually get cholesterol buildup on your tendons. So when you feel a patient's hand or move over a tendon, you can actually feel the plaque that's developed there. Wow. And then those are the main ones that you can see when you look at a patient. And then the other things, of course, are when we start to develop the vascular complications of the lipids.
Wow, it's fascinating. Fascinating. And then in that same vein, how often should I get tested? And is this a test that I can ask my doctor for, or is it prescribed? You mentioned there was one test that cost $99, that calcium score test cost $99. Can I ask my provider for a cholesterol test? How does that work?
So how often you should get a cholesterol test probably depends upon what your risk is. So, we definitely want our kids to all be tested prior to puberty so that we can try to identify which children are going to be at risk for early heart disease. It will drop during puberty, so you really want to catch them before they hit puberty. And then it'll bounce back up in their early years. So you want to make sure you're looking again at about age 18. When they're young and they don't have any risk factors and it looks beautiful, you could do it every 5 years. For individuals that are under active treatment and we're adjusting medicines, we might be checking in a month or 3 months. So it really just depends what is happening and what the risk is.
What is happening, what the risk is. Okay.
All
right. Go ahead, Dr.
I was just going to say, when for women as well, in menopause, your cholesterol really changes. Men's cholesterol often stabilizes by about the age of 55, but in women, as we go through perimenopause and then menopause, our cholesterol continues to rise, particularly the LDL and triglycerides, and the HDL begins to go down. And the HDL has 5 subunits, only one is cardioprotective. And so you don't know based on your labs which one you have the most of. So I tend to test my women a little more frequently in the perimenopausal and postmenopausal period because their cholesterols are changing and they don't know that. They thought they had great cholesterol all their youth, so things change then.
Yeah. Okay. Well, that's good to know. I'm going to share that information with my girlfriends too. So, okay. We've got some 2 other questions, but we're going to go to them and we'll see what we can do. So if you're taking cholesterol reducing medication, which has been highly effective, as you all have shown, how many eggs would be the recommended limit per week?
Is it okay if I take it? All right. So our poor little eggs, they always get picked on. The cholesterol in food is not really relevant. Our body makes as much cholesterol as it needs and recycles as much as it needs. So it's really the saturated fat in foods that you're worried about. And so when you think about how Americans eat eggs, they cook them in butter and they eat them with bacon and sausage. It's probably the butter and the bacon and the sausage that are problematic. The egg is a complete protein. It's beautiful, and it's one of our few foods that have choline. It has a beautiful B12 to it. So it just depends upon how you prepare it. And it depends upon what your underlying risk is, If you're doing fine, then probably an egg a day is fine. If you're someone who's really struggling and we need to tweak a little bit, then maybe we'll go down.
Okay. Get hard-boiled eggs, okay?
Well, a fried egg is fine too. Do it in some olive oil.
There you go. And not coconut oil. There was back and forth on that. Okay. All right. And then our final question tonight is, how can I participate in a cholesterol mindful nutritional counseling session? That's a great question to add on.
Go ahead, Deb.
I would say, find a registered dietitian who is very focused on cardiovascular health. And, we're never looking at one food or one measurement. We are looking at you as a whole person and a whole eating pattern. So as I said, our eating patterns are never going to be perfect. And so we just want to be able to understand, if there are certain favorites, certain indiscretions that we really like, how do we fold that into an overall healthy eating pattern, looking at size and frequency?
And also looking at, are you a stress eater? Some people eat when they're very stressed and they go for the things that are not healthy. And some people just eat for any emotion. So if that's something, then maybe you want to meet with a counselor to kind of explore that aspect of why you make the food choices that you make.
Yes. It's so relatable. It's so relatable, and we're not perfect. We're all doing the best we can. And so it's great to have this discussion just to see where we can make these, small improvements for a bigger change for the outcome. So Dr. Ashley, Dr. Koehn, it was such a pleasure to have you all here with us today. Thank you for spending time with us and sharing with us so we could learn more about Pauley's Lipid Management Clinic and cholesterol. And if you need, if you want to reach out to us, you can certainly do so. You can see it on your screen. We've got VCU Health at VCU Health Heart on Facebook, and we're also on Instagram. So once again, Dr. Ashley, Dr. Koehn, thank you so much for joining us this evening.
Thanks. It was a lot of fun.
Yeah. Thanks for having us.